Okay, let's have a short discussion about infertility and how to do the workup of infertility in our setup in Somaliland. Infertility definition is unable to conceive. The couples fail to conceive in 1 year or after 1 year of unprotected sex with a reasonable frequency of intercourse, which means around 3 to 4 times per week in different days. The prevalence of infertility is around 10 to 15% in reproductive age couples, which means that most of the couples are subfertile but not infertile. Infertility, we have two types of infertility: primary infertility and secondary. Primary means those patients or couples who have no conception before, and secondary is those who have period conception or period children, regardless of whether it's abortion or a live birth, but instead of conception. Fertility is chance of getting pregnancy in one cycle, which is 20 to 25%, which is increased up to 60 to 70% in 6 months and up to 85% in 1 year. And if we add one more year, there may be again another 5% may get pregnant. The etiology of infertility can be shortly summarized into ovulatory dysfunction, which is 27%, the commonest one. Then male factor infertility, tubal and uterine factors of 22%, unexplained infertility of 17%, and other factors or other minor factors of 9%. So to evaluate, we have to evaluate female infertility evaluation and male evaluation. For evaluation of female patients with infertility, we need to have these three evaluations. We need to evaluate their ovulation. Is she ovulating or anovulating? Evaluation of ovarian reserve and evaluation of anatomical abnormalities. So evaluation of ovulation or anovulation, we have different methods, direct and indirect method. To evaluate the anovulation, we can take from history, menstrual pattern, if the menstrual cycles is regular, coming every fixed time, then we can consider this woman is ovulating, especially if the cycles are having the associated minimal symptoms like mood change or mood swings, food cravings, and some mild abdominal cramps. The abdominal pain should not be severe because it will indicate endometriosis. Other thing that we can use for evaluation of ovulation is basal body temperature. The woman may measure her body temperature. Normally, in normal cycle, it's biphasic temperature. Temperature is low in the early part of the cycle or during the follicular phase. Then the luteal phase, it increases. The temperature increases due to progesterone effect in thermoregulatory center. The woman will measure the temperature vaginally or rectal temperature every morning. The vaginal temperature every morning when she wakes up before she gets out of bed, and she will document it in this. It will be drawn like this chart or this curve. Then they will find this biphasic temperature, which means the woman is ovulating. But practically, it's not used for because it needs long time. It needs patient cooperation. There are some factors which can give you false positive or false negative. For example, if the woman is having another cause of fever, for example, infectious things, then their temperature may be different or may be highly elevated in who we may not find this biphasic temperature. The other thing is, if the couples will notice that the biphasic temperature when they reach here after they pass the ovulation, so this will not help the couples who are trying to conceive. The other thing we can use is ovulation prediction kit, which is that's used from urine, and it's a urinary luteinizing hormone. It's a test. This test is checking the LH hormone from the urine. And the test is begins before 2 to 3 days before the predicted LH search, because first we should predict the ovulation. So the time that we think that the woman will ovulate, 2 to 3 days before that, then she will test daily. And when she gets positive LH search or peak LH search, the ovulation will occur the next day to that. If the woman cannot decide the LH search is positive or not, she can repeat the test again in the same day in the afternoon. The other thing is endometrial biopsy. Endometrial biopsy is not commonly used for evaluation of infertility because it has greater inter-observer and intra-observer variability, but it can be used to diagnose luteal phase defects. The other thing is serum progesterone. Serum progesterone is very important simple test that's available in our setup, which is a measurement of mid-luteal phase progesterone. In progesterone, in luteal phase, especially at day 21 of the cycle, the progesterone should be elevated more than 4 to 6. It means the woman is ovulating. There is ovulation happening. And mostly if it's more than 10, you can diagnose the woman is ovulating. So we can use both to check whether there are drugs. For example, you give a woman a drug for ovulation induction, you can use this to check whether the woman is ovulating, whether your drug is working, or whether normally the woman have ovulated this cycle or not. Other thing is sonography. Sonography to check for ovulation is a transvaginal sonography repeatedly every day during the follicular phase, especially late follicular phase, to see the follicle forming, deforming, growing, then collapse of the follicle, which means this follicle have ovulated. But it's not used commonly in real practice because it needs serial transvaginal ultrasound and it's quite invasive. And there are simple methods that we can check the ovulation. After we check the ovulation, the other things that we need to check for ovulation, for example, there are some endocrine disorders which can have effect on ovulation, especially the thyroid and prolactin level, because prolactinoma or hyperprolactinemia and both hypo and hyperthyroidism can have effect on negative impact on ovulation. After that, we can check that we need to evaluate the ovarian reserve. Does this woman have enough adequate ovarian reserve? And this is done by checking day 3 of the cycle. This test should be done the third day of the cycle, but it should not be randomly. And FSH, follicle stimulating hormone of day 3, normally when the woman have adequate storage, the FSH is mildly elevated or it's low range, but if the woman is premenopausal, near to be menopause, or have no ovary, or for example, the woman is with premature ovarian insufficiency, FSH level is high. So we should do FSH and D3. Doing estradiol may not add any value, but sometimes if you suspect these results may be false, then you can use it to help with the interpretation of follicle stimulating hormone level. But FSH only is enough, but it should be on D3. The other thing is AMH, anti-Mullerian hormone. AMH is better than FSH because it don't need to be specifically of the cycle. The other thing is it will tell you more information than FSH because it's secreted by small periantral follicles, small follicles. So it will tell you the real reserve of the ovarian follicles. Antral follicular count can be done through with ultrasound, transvaginal ultrasound, but it's not usually done in our setup. It's used for those who are in fertility treatment for IVF treatment. The last thing that we need to evaluate for female infertility is anatomical abnormality. Anatomical abnormality to peritoneal factors which may be due to damage or obstruction of the fallopian tube, mostly from PID or infections. Evaluate that you may find from history the woman having pelvic pain, dysmenorrhea, which may suggest there are tubal obstruction and adhesions. Tubal infertility is 12% after one episode or after one time PID, but if the PID occurs again in the second episode of PID, it may reach 23. If there's 3 cases or 3 times PID, the woman get 3 times PID, the chance of tubal infertility reaches up to 54%. So to evaluate the tubes, we need to use hysterosalpingography or laparoscopy and chromotubation and hysterozonocontrast sonography, which is ultrasound. Use it ultrasound after they mix ultrasound after they instill their uterus. Normal saline mixed with another chemical which is making a multiple small air bubbles. Then you can see this air bubble flowing through the fallopian tube. Then you can find the size of your obstruction. Hysterosalpingography is available in the country and it should be done day 8 to 11 of the cycle. Laparoscopy and chromatoblation can be done effectively, but it may not. It's quite invasive. So if you have hysterosalpingograph and hysterozono contrast sonography, you better use the other two. The other anatomic abnormality that we need to test is the endometrium, the uterus inside the uterus, because the uterus can have genital malformations, there may be polyp or leiomyoma, Asherman syndrome, or due to other causes like infectious causes can lead to distortion of endometrial cavity. So to check that, you can use hysterosalpingography or transvaginal sonography with or without saline infusion. The one which is more helpful is saline infusion sonography, hysteroscopy, laparoscopy, or MRI is especially considered the congenital anomalies of the uterus. And what we have in the country is hysterosalpingograph, transvaginal sonography, especially saline infusion sonography, and MRI. Hysteroscopy may be available in only one place, and it's not. And laparoscopy for diagnosis is not available in the country. Cervical factors is minor things and mostly it's not run, but you can see from the history, from the patient's history, if the patient has any cervical procedures like lip or cervical conversation or cryotherapy, then you may consider there may be cervical factor infertility, but it's not that much important. So lastly, how it's done in Somaliland. Somaliland, we have different good setup of or different collection of laboratory tests and workups that can be utilized. لكن عاديا sida saxda looma sameeyo waxaad arkaysaa qof kasta wax loo diray FSH si maalintii la doono la diray taasoo aan la sharixi karin aan patientkii la caawin karin image lama isticmaalo waayo availabilitygeeda yar meelo yar oo keliya taa laga helaa LH qofka loo diro LH qofka loo diro marka FSH loo diro iyaduna faa'iidada ay soo kordhinaysa male sidoo kale estradiol in qofka u dirto faa'iido ay kusoo kordhinaysa daweyntaada iyo howlaha oo dhan male laakiin LH waxaad u isticmaali kartaa si aad u eegto ovulationka oo aad eegayso urine LH kit progesterone iyadoo dad badan oo sameynaya waan arkay laakiin si saa loo sameeyay idan wax ka khaldan waa inay noqoto D21 say kaaga caawiso in ovulation ayay kale in isku ogaato thyroid function test iyo prolactin levelka wala sameeyaa waa okay oo fiican iyagu organ function testing qofka loo sameeyo qof kasta oo infertility ka cabanaya iyadoo muhiim ah haddii aanad ka fikirin qofkan inaad daweynayso qofkan uu qaadi doonto aad sidoo kale ka fikirayso inay leedahay kaliya xanuun ama wadna xanuun iyo waxaas ama beer xanuun ayaad u diri kartaa organ functionka MRI wax loo baadaa si yar laakiin sidoo kale dadka qaar baa aaminsan in myomada iyo ovarian cystic ay keenaan infertility laakiin waa in la ogaado labadaas inaanay waxba saasa keenin. That's all for today. Thank you.